Hello and welcome to this first application of Tech Tape. My name's Dave
And I'm Dan.
and we're here to patch up some holes in our knowledge.
Maybe yours.
In these videos we'll be touching upon topics such as first aid, pre-hospital care,
Yep. Anatomy, physiology.
pharmacology.
Yeah. This episode, we'll be starting where everybody probably should, with what to do if you're faced with an unconscious patient. You might need to also do some scene safety.
That's true. Later on in the video we're going to talk a little bit more in depth about scene safety, risk assessment and assessment of an unconscious patient. And we'll probably discuss some of the tools and ideas that might help you get through your OSCEs or just help your way around the road. But I'm going to take this moment to take a little bit of break from that. We're going to step back. We're going to take a breather, Dan.
Okay.
And I'm going to ask you, how's your imagination?
Well, funny you should ask. I think it's starting to fire up.
So, unlike mine, it hasn't yet been ruined by YouTube.
No, it hasn't.
Oh well. Well, being as you can imagine things, I'm going to ask you, Dan. I want you to just sit back, relax, and I want you to imagine it's a nice sunny day. Ignore the clouds, it's a nice sunny day. You're out for a stroll. While you're walking along, you stumble across what you think appears to be, to you, to your eyes, an incredibly handsome unconscious patient. Dan. Well, gang, we can't sit here all day waiting for Sleeping Harry over here, can we? Better crack on. Now, I appreciate most of you are probably aware of the Dr. ABC approach for an unconscious patient. For anyone that's not familiar, that would be dangers, response, airway, breathing, and circulation. Now, the keen-eyed among you may have noticed I've included the catastrophic hemorrhage and C-spine assessments in ours. You can also expand this with D and E for disability and exposure. If we don't tag that on the end of this, we'll add it into another trauma video. Now, what I like best about this method is you get your D in first. That means check for dangers. Take a deep breath. Survey the scene. Remember, your primary concern as a first responder is your safety. At this point, you're responsible for yourself, your crewmate, and any potential casualties. That said, don't spend all day about it. Keep it relevant to the scene you're approaching. In the case of an OSCE, keep it relevant to the scenario you've been given. Use your common sense and a dynamic risk assessment. You may be going into a situation that's dangerous. There may be a high risk of injury or violence. Don't be afraid to use a judgment call. Shout for help if you need it, and back off if it's necessary. You're no use to anyone if you're on the deck as well. To add to that, you'll have just doubled the amount of resources required and reduced them by 1. Whoops. But this isn't the time to get carried away. We really need to move on and get on with response. And I think I've got a fairly good idea of a way to show you. So here we have a slumbering Dan. Now I don't know about you, but I can't carry this on for much longer, so I'm not going to bother. I'm quite happy to say that he's not alert and talking to me. But is he responsive to voice? Let's find out. Dan! Dan! Are you choking, Dan? Walkies! I'd say it's pretty much beyond that as well. We need to test for a pain reflex. We can do this in a few ways, normally building up and escalating. We'll start by shaking the shoulders, stroking the eyelashes, testing for a reflex response. But, being as it's Dan, we'll start with a pen. Dan!
So, I was having a wonderful daydream there.
Were you having that dream again, where I'm unconscious and you're running through the 2010 UK Research Council guidelines?
Maybe.
It's so predictable. But it does lead us very neatly onto our next point.
Next point?
Oh, yeah, sorry, man. While you were sleeping, we've briefly covered dangers and response. If you promise to stay calm, you'll see that I've already written them on the board as well.
Dave, it's as good as the last time we saw an ambulance.
Yeah, nearly, man.
So, hold up. Did you talk about checking for dangers?
We did, yes.
And you say you've done response?
Well, we got to pain.
Including you?
No, I did it. You were asleep.
No, not you. Unresponsive.
No, not yet.
Well, did you mention how following some conditions such as hypoglycemia or epilepsy, patients may wake up confused and disorientated?
No, but that's a really good point. Should we put the D in again?
Well, did you mention dynamic risk assessments?
Did give me some credit.
But it is worth bearing in mind, where possible, try to ensure you're out of arm's reach and preferably in a position where any potential swings will be misses.
That's a pretty solid piece of advice and well worth remembering, I think.
So just let me catch up again because I've still got a bit of a fuzzy head. If you fail to tick any of the above boxes, then you're unresponsive.
Where your patient is.
True. But at this point, if you're alone with this patient and have come across them as a bystander, you would try to gain some help. If you're there as a responder, you could start thinking briefly about your access and egress routes as well as any backup you may require.
Dan, being as we'd be assessing AVPU on approach to the patient, would it also be worth talking through the patient assessment triangle?
We've got it up on the board, haven't we?
We have. Now, this was initially introduced as a tool for quickly assessing children whilst approaching, and it's actually a very fantastic tool in that setting, and I would suggest giving it a search because we're probably not going to do it complete justice here.
It can be applied to most patients during your approach and may give an early indication of how stable your patient is and can be a very useful tool when combined with AVPU, which Dave apparently showed you earlier, and can be helpful in quickly identifying how serious the patient's condition may be. First, Dave, we'll be looking at their appearance.
Fine, if I may say so myself. However, this is a very broad term and covers a abundance of features. We're going to be looking at how alert they are, their positioning, how are they interacting with you? Do they appear dazed and confused? This may help you to start thinking about some of the underlying causes that may be initiating any of the changes you see.
So next up, we're looking at the work of breathing. Here, we're going to briefly assess the patient's breathing from a distance. So we'll be checking to see if we can note any breathing firstly. If they are breathing, we'll take note of the rate and effort that they're putting into it. We're looking for any changes in positioning that may denote some kind of respiratory distress. Dave, if you would, The tripoding position, so leaning forward to allow extra expansion of the chest or use of additional accessory muscles around the neck. Finally though, we'll be looking at the circulation to skin.
Yeah, that's true, Dan. We're going to be looking quickly at the patient's skin. We're going to assess the colour, questioning things like, are they pale, mottled, cyanosed, clammy? These will all give you an indication of whether there's any kind of issues with general perfusion. I think that probably concludes the patient assessment triangle for now though, Dan.
Yeah, I think it does. So you'll find yourself applying scene safety checks, AVPU and the patient assessment triangle all together to create a global overview of the situation before you really make contact with the patient. We can move on to catastrophic hemorrhage in that case then, Dave.
Indeed we can, Dan. But what is it?
Catastrophic hemorrhage.
Yeah.
It's a loss of blood that's likely to cause a risk to life. It was initially adopted into the ABC approach by the military, where patients had experienced massive trauma and ballistic injuries. It was later added into the civilian approach after being proven effective on the battlefield. While approaching the patient, we're looking for any evidence of any significant blood loss. At this point, only external blood loss will be evident and should be easy to spot. More likely than not, it'll be an arterial bleed. So we're looking for bright red blood that's most likely to be pulsing or spurting. However, if you are dealing with a trauma patient, it might be worth quickly looking around any hidden cavities. So checking places such as under the legs or the torso. You're clear.
I think we're good. The reason this is a primary concern is because any following assessments and interventions would be futile without an adequate circulating volume in the body. Anyone that knows anything about blood will be able to tell you that it transports oxygen around and carbon dioxide away. This ultimately maintains homeostasis, keeping the tissues alive at a cellular level and maintaining the acidity level within your body.
This is considered immediately life-threatening. If you find any catastrophic hemorrhage, you have to correct it before you can move on. You'll have to act quickly to stem the bleeding. This would involve substantial pressure on the wound and elevation above the heart if possible. We'll discuss trauma in later videos, but it's worth mentioning you may need to consider a tourniquet at this point if you can't control the bleeding manually or through pressure bandages. You will need extra help. Consider using bystanders to assist you if you haven't already. Fortunately, Dave's not experiencing any significant blood loss, and if your patient isn't also, you can move on to the airway.
Yes, Dan, A. In your unconscious patient, A is for airway. Now, we'll do a more concise video regarding the anatomy and physiology and some management techniques and adjuncts, but for the purpose of this video, we're just going to touch upon it briefly. By this point, you've established you're dealing with an unconscious patient, and luckily, their blood is still in their body. But we need to know, can those gases actually exchange inside the lungs and get in and out of the body? We need to quickly open and check the airway, looking into the back of the mouth for anything that may compromise or hinder their breathing. Consider things like wounds to the face or upper airway that may cause bleeding. If your patient's unconscious, their muscle tone is going to be greatly reduced, so consider vomit occluding the airway. Dan, would you like to add anything?
Yeah, a few ideas for foreign objects may include food, toys, especially around children, and teeth. Teeth are always worth remembering, so look carefully to see if your patient's got any missing or if their dentures are out of place. Dave, where do you put your dentures? These items you may be able to remove with tools at your disposal, so say gloves or McGill forceps if you can see the object. Blood or vomit, as Dave alluded to earlier, could be cleared by postural drainage. This would involve potentially tipping the patient's head or body to one side to allow it to drain. However, primarily use suction if available, and you're trained to do so. Look for swelling inside or outside of the airway. This could cause the airway to close up entirely. If there's evidence of fire, check for smoke or singed hairs. This could potentially cause swelling.
Some of the basic management techniques you could consider would be head tilt, chin lift, jaw thrust, and you could consider moving on to adjuncts if you feel it's necessary. As with any of the other steps, you can't move on till it's corrected.
Which I think is a good tie to the next little C. The assessment and control of the C.
Whoa, Dan.
Yeah?
I think we need to bear in mind at this point, you can't control the sea, me hearty.
No, you can't control a pirate, Dave. We could talk an awful lot about the C-spine, and we will in another episode. For now, Dave, what you need to know is the C-spine refers to the cervical spine. This is the first 7 vertebrae below your skull leading down to your shoulders. They're pretty much on their own there, supporting your head and spinal cord. So if you've got or suspect a high mechanism of injury, you need to consider this. But don't forget, A still comes first.
Yeah, at this point you can feel down the back of the spine. We're just feeling for any sort of deformity or crepitus. For now, as Dan said, if you're suspecting a high mechanism of injury or you're in doubt, try and keep your patient in a neutral position with the support of colleagues or bystanders and consider a collar to secure if you think it's needed. Dan, can we move on to breathing?
Assuming we've got this far without any issues, we'll have to assess the patient to see if they are breathing. Generally, this can be done with a hand on the chest and your ear and cheek near their nose and mouth. This is to allow us to look, listen and feel for breathing. We'll do this for no longer than 10 seconds. If we don't feel anything, we will assume they aren't breathing. If you're a bystander, at this point you would move on to CPR.
However, Dan, we'd next move on to circulation. Again, this means looking at feeling for a pulse for no more than 10 seconds. Initially, we would perform this by checking for the carotid artery. This is to ensure that we've got blood flow to the brain and other major organs. So, assuming they're breathing and they've got a pulse, I think you can write some of your favourite letters on the board, Dan.
A, M, B.
Dan,
Not them.
I was thinking RRV.
Oh, rapid response vehicle, of course.
Well, no, in relation to breathing and circulation.
Oh, sorry. Rate, rhythm and volume.
Yeah, we'll start with breathing, because I think oxygen's important.
Agreed.
When we're talking about breathing, we're talking about respiratory rate. Respiratory rate for an adult would be between 12 and 20. Anything less than 10 or above 30, and we'd be considering interventions through means of ventilation. This is because above or below that range, your patient will be shifting too much air or too little to oxygenate efficiently. It's worth noting that with children, this rate will be faster, and it does vary with age. So you might want to check before you arrive on scene. So, Dan, I couldn't find a rhyme. Have you got rhythm?
Dave, I've definitely got rhythm.
Awesome.
Basically though, we're just assessing the regularity of respiration. So is it regular or irregular? Irregularity could be a sign of respiratory distress, even if their rate appears to be normal. So again, consider interventions or assisting ventilations if they do not appear to be adequately perfusing, which leads us to...
Volume! Everybody's favourite, especially mine. The normal tidal volume for an adult would be 500 millilitres. Although you're probably not going to be able to definitively measure this on scene, it does give you an idea of what kind of rise and fall you'd expect to see on the chest to enable gaseous exchange to sustain life. Luckily as well, the RRV model can be used to assess the efficiency of circulation. We've talked about assessing circulation on approach, but you can reassess it here, and this is where we get hands-on.
To establish a rate, you will need to find a pulse. There are four main ones we may assess at this point: radial, brachial, femoral, or carotid. Whichever one you check, you'd still be establishing the rate. The normal rate in an adult would be about 60 to 100. Anything outside of this range will give you cause for concern as to why they may be unconscious. However, it must be taken into consideration with other factors.
One of these factors would be rhythm. How regular is the pulse? This is why we're hands-on, as monitoring equipment can give a slightly different or false impression. We're looking for how regular the pulse is. If it's irregular, how irregular? Is it regularly irregular, or is it irregularly irregular?
You're quite often irregular, Dave, but I'm quite often regular.
Dan, I would say that you were irregularly regular.
We also need to assess the volume. This is why we would normally begin assessing for the pulse distally by locating a radial, and generally a radial pulse present is accepted to indicate a blood pressure with a systolic value above 90, which would normally be adequate to perfuse all of the tissues throughout the body, assuming no other compromise. If you can't locate a radial, you can then begin to work in centrally with a femoral or carotid pulse. If both are present, it can be assumed the blood pressure is about between 60 and 80. Carotid being the last to drop out at anything below 60. We're also looking to feel the strength of the pulse. So is it weak or thready? That might indicate issues, as may a pulse that is overly bounding.
Bounding off the walls, Dan. Essentially, we're trying to establish that there's a level of perfusion adequate enough to maintain homeostasis. That's why we're combining palpable pulses with circulation to skin. Is there any other way we could do that, Dan?
We could check the capillary refill.
What's that?
It's just a quick assessment for how well a patient is perfusing by assessing the blood flow to their capillaries. You can take your nail bed on the end of your finger, hold it down for 5 seconds so it becomes pale. When you release it, it should go back to normal colour within 2 seconds.
Could we do that centrally as well? Say sternum and forehead?
You absolutely can, Dave. You could take your top off if you want to demonstrate.
No, they do not need to see that.
Neither do I.
They've stuck with us this far. I don't want to scare them off. Possibly worse, create a fan base of groupies. Let's just say you could do it on the sternum and the forehead, anywhere that will remain perfused during the initial stage of the shock.
But that's another topic for another video, Dave.
Agreed. I think we've covered enough here today. And to be brutally honest, mate, I could use a cup of tea. What have we learned?
Well, hopefully we've covered the basic points on dangers and staying safe,
Patient response and AVPU.
catastrophic hemorrhage, and why it's important.
A brief overview of the airway and C-spine.
Equally brief overview of breathing and circulation.
Well, I hope you stayed alert with us. Well, me. Enough to stick with us through this video and voyage through the 3 C's!
Dave, you've got to stop doing that.
Hopefully you've learned something. If not, at least found it enjoyable enough to stick with us for future videos.
Yes, thanks for watching. Remember, you can use the box below to tell us if you liked it or disliked it, or tell us anything you would like to have seen included or not included, or done differently.
Indeed, you can give us any ideas or topics you'd like to see us cover, and hopefully we can go into a little bit more depth in some of those. And don't forget to subscribe to future videos of Tech Tape.
Tech tape! I said don't do that, mate.
Caterpillar refill.